Welcome everyone to today's webinar, How New Guidance on Enhanced Indoor Air Quality by the CDC and ASHRAE Will Affect Hospitals. My name is Erica Spicer-Mason, and I'm a writer and editor for Becker's Healthcare. On behalf of all of us, thanks so much for joining us today. Before we get started, I just wanted to walk everybody through a few quick housekeeping instructions. We'll start today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link that you used to log into today's webinar to access the recording. And if at any time you don't see your slides moving or if you have trouble with the audio, just try refreshing your browser. And you can also submit any technical questions into the Q&A box. We're here to help. With that, I am pleased to introduce today's speakers. We have with us Dr. Edward Nardell and John Palfreyman. Dr. Nardell is a pulmonologist and TB specialist with a 40-year background in the study of airborne infection and transmission control, with a special focus on the built environment. He was mentored for 18 years by Dr. Richard Riley, a pioneer in airborne infection and transmission control, and himself a student of William Firth Wells, and perhaps the greatest authority on airborne infection and control of the 20th century. Dr. Nardell has more than 110 peer-reviewed publications, including some of the most important research on airborne infection control of TB and GUV. Particularly relevant to today's topic is his 1991 paper on the theoretical limits of building ventilation in controlling airborne infection and its relation to infectious source strength. And John Palfreyman holds a degree in chemical and nuclear engineering from the University of California, Berkeley, and an MBA from the Yale School of Management. Before joining R0, John's background included engineering and consulting experience in the energy sector, value-based primary care networks, and software as a medical device industries. John now leads product strategy and product marketing at R0. Dr. Nardell and John, thank you both so much for being here today. I will go ahead and turn the floor over to you. Thanks so much.
Thank you so much, Erica. Thank you for those introductions. As folks probably noticed, Dr. Nardell is the real expert here. I'll probably take lead on going through some of the higher level content so we can all be on the same page and give as many opportunities to Dr. Nardell to really get into some of the more interesting details behind what we see going on here. So as an overview, we already went over the quick bios. Then we'll go through the basics of these new guidelines, sort of what are they, where are they coming from, why are they needed, and then the specific numbers that have been set. And then we'll go into what does this mean for healthcare organizations, what technologies can be used to comply, and sort of what are the next steps that organizations should be taking. And then we'll leave plenty of time at the end for Q&A. So with that, we'll go ahead and get into it. So overall, what's going on here? It was about a month ago now, I believe, that two very prominent organizations, ASHRAE and the CDC, released new guidance on ventilation standards for the control of infectious diseases. Both of these organizations in the past have provided ventilation standards, but they weren't targeted or with the intent to control and mitigate the spread of infectious airborne diseases. I'm sure many of you are familiar, if not all of you are familiar with CDC, or the Center for Disease Control and Prevention, but there's a lesser known but very important organization as well called ASHRAE, which is basically a professional society organization of HVAC engineers, and they set the standards that end up forming the nation's building codes. So they're a little bit more behind the scenes, but the work they do tends to have pretty profound effects on, the ventilation standards and codes that were held accountable to, at least in the United States, and they actually have they're quite influential abroad as well. They released a new draft standard, so it's not yet finalized, but they've committed to approving the final standard by the end of this month, actually. But the draft standard was released, and the purpose of it is to control infectious aerosols and reduce the risk of disease mitigation. And they set specific standards based on occupancy and the space type. On the other hand, CDC, they released guidance, and they've recommended at least 5 EACH in all occupied spaces, as well as upgrading all MERV filters to at least MERV 13 in these occupied spaces. So the CDC has released guidance, and ASHRAE is releasing what will likely end up becoming part of building codes. Dr. Nardell, could you speak to the influence of these two organizations, and especially ASHRAE for those who are less familiar, and to what extent do these organizations sort of work together or independently and collaborate here or not?
As a non-engineer, I'm not intimately familiar with all the operations of ASHRAE, but I've certainly been aware of it and interacted with it. I've been on ASHRAE committees over the past many years. So ASHRAE is a professional organization of engineers, and it is it very much is a consensus organization of its own experts that, as you said, very much influences building codes. It is, I would say, a bit biased toward air moving strategies because of the nature of its organization, which is the name stands for American Committee, is it? Or American Society, I'm sorry, American Society of Heating, Refrigeration, and Air Conditioning Engineers. So it is very much oriented toward mechanical ventilation and filtration. And it's not surprising that the guidance is very much focused on those areas. Interestingly, ASHRAE also has another committee which is far along in developing guidance, for example, for germicidal UV, but you would not know that from the document we're going to be talking about. CDC, on the other hand, is a much more general organization providing, as we experienced over the COVID pandemic, guidance on disease prevention, mitigation, and along with that, and particularly for infection control practitioners in hospitals and healthcare settings, it is the place that we tend to look for guidance on respirators, and including that on ventilation in isolation rooms, in common rooms, but very much more general. As far as I know, the two organizations have no formal interaction, and I would say that the processes, although coming out very similar, were probably independent and probably not in any way coordinated, and the results are quite different, actually.
Absolutely. Thank you. So if we jump here, sort of the question that comes up is why now? Both of these organizations are releasing these around the same time. And as you might have guessed, COVID-19 is obviously a huge influence, sort of changed our lives, changed the world over the past 3 years. And while it's not news that IAQ and ventilation are important approaches for reducing the risk of airborne risk mitigation, it just wasn't front and center before the COVID-19 pandemic like it is now. These sorts of big changes really do take time, and this was obviously brought up over and over as one of the most often cited recommendations was to increase your ventilation to reduce the spread of COVID-19. But what's brand new is not that's certainly not novel, but what's new is setting a specific numerical target. So in the past, it might be, okay, I increased my ventilation. Am I good now? How much is recommended? And that's really what's changed and what could be really big here. So both ASHRAE and the CDC, as mentioned, have actually put numerical targets on it now. And I think one of the important things here is, while I think COVID was certainly the impetus for making these changes, it won't only help with COVID, but any future outbreaks of airborne infectious diseases, RSV, flu, and more. So Dr. Nardell, with your extensive background and sort of research experience, how did the pandemic either shine a light on your work or maybe change the direction of your work? And just how big of a deal do you think these new guidelines are? Will they have a positive effect on public health?
Well, first of all, as mentioned in my bio, I came to this from the perspective of tuberculosis, which is unequivocally airborne. One of the reasons why we're probably getting recommendations now is that it took quite a while into the pandemic for there to be consensus about the manner in which COVID-19 was being spread. Initially, as you remember, people were cleaning grocery bags and all kinds of things having to do with contact and droplet spread. And even, I would argue, in the current ASHRAE document, there is a little bit of inconsistency about near field and far field transmission. So I think that my own work, because of the tuberculosis is airborne and exclusively airborne, not spread by contact to any significant degree at all, it made it very easy for me to focus on the built environment. I started with a homeless shelter in Boston and an office building where there had been transmission, and focus on that arena. And it's been gratifying, I should say, that because very few people are extremely concerned about tuberculosis in this country. So a lot of my work on germicidal UV and on the limits of ventilation, for example, were not of enormous interest here, but abroad in other parts of the world, where TB under non-pandemic times is still the #1 infectious killer of adults. So it's been gratifying to see this interest now in ventilation, filtration, air disinfection, and airborne infection. That said, in the past, actually, when I started in this field, there was a consensus among engineers that if a building was, quote, healthy, that it had good ventilation as defined by ASHRAE for comfort, which is what ventilation has been designed to do, to basically reduce odor, remove CO2. Providing enough oxygen is never a problem in buildings generally, and delivering dehumidifying, cooling, or heating. But all of that can be done with relatively modest amounts of ventilation, and that's what most building ventilation systems are designed to do. Several air changes per hour, but and for years, CDC had in their documents that for isolation and procedure rooms, something like 6 to 12 air changes per hour were recommended. And that was based on really, if you had a contaminated room with airborne something, how long it would take to clear that. But it was really not based on ongoing production. So it was really under static conditions. And so 6 air changes, you're allowed to go in that room fairly quickly, and then with 12 air changes, even more quickly. So it was about clearance of contamination. With COVID, now belatedly, we're asking, okay, we want to increase ventilation, but how much? And so that's where ASHRAE has come in with its recommendations, and CDC as well. And I think CDC's recommendation, as we'll discuss, is, I would say, a practical recommendation of an achievable amount of ventilation, and is based not on occupancy, but on room volume, essentially. And it assumes that there's a certain amount of occupancy that rooms will accommodate. ASHRAE, on the other hand, has gone to a per-person recommendation, which makes a lot of sense for things like heat, CO2, which are generated in proportion to the occupation of the room. So if you have a very crowded room, you need much more ventilation to get rid of the CO2, get rid of the heat, get rid of the humidity. With airborne infection, you may have a crowded room, but still only one infectious person. So it makes less sense to me to base it on occupancy, but that's what they've chosen to do. And in the long run, there's a lot of overlap between these two ways of recommending ventilation. So I think to get, not go on and on, these are overdue recommendations, and I would say that the ASHRAE recommendations were made rather hastily and are now under review. I submitted my comments, as have many other people, and we'll see what actually comes out. I would not take the current recommendations as set in stone. I hope they're not. And CDC recommendations, however, are not under review. Those seem to be their opinion of what should be reasonable, and I would tend to agree with them. I think 5 air changes is more than comfort level ventilation, but also probably within the realm of the feasible, without complete renovation of the ventilation system. Are either enough? We'll talk about that.
Yeah, thank you so much. And that's the perfect lead into where we're going. So some of you might be asking, so what are these numbers we've been talking about? Obviously, that's the point of this conversation, is to give this sort of preview of what we might be looking at. So what this table does is basically summarizes the equivalent ventilation targets across the current standard, which for healthcare is called ASHRAE 170, and the forthcoming standard, which is called 241P. We've shown here a number of different industries, not just healthcare, just to show that this is a broader action and going to be a broader trend across the US. And there are significant increases being proposed across the board. But obviously, we'll want to focus today on healthcare. And there, if you look about in the middle with the gray background, you can see what Dr. Nardell was talking about. 6 to 12 air changes, patient rooms, I believe it was 4 in ASHRAE 170, but in that range typically in most healthcare spaces. In the forthcoming standard 241P, you see that going up to the range of 8 to even all the way up to 40 EACH in waiting rooms. And what that looks like is a significant increase across the board. On the low end is a 33% increase, which may be a bit more practical and feasible with current infrastructure in place and building controls. When you're looking at tripling or a 6x multiple of the status quo, that becomes quite a bit more difficult. And quickly, just to make sure we're on the same page, I'll mention EACH just stands for equivalent air changes per hour. Dr. Nardell, you may want to go into that more, but overall what we've done here, ASHRAE 170 lists their ventilation targets in ACH, whereas 62.1, which is the standard for non-healthcare environments, lists theirs in CFM, or cubic feet per minute. And the forthcoming standard 241P lists theirs in CFM per occupant, and they describe it as EOA, or equivalent outdoor air, basically air that's not infectious, that doesn't have those infectious microorganisms in it. What we've done here is sort of standardize across the board, so you can look at it apples to apples and get a comparison of the sort of the before and after in terms of EACH. And to do that, you make some simple assumptions around typical occupant density and room dimensions. But if you were to go in and do this yourself for your specific space, you may see slightly different EACH numbers based on differing room dimensions or occupant density. But overall, we see a pretty big increase across the board, as I mentioned. So Dr. Nardell, where is your sense of where these targets landed in terms of being realistic, aggressive, effective, and if implemented, do you see an improvement in protection for the next big outbreak or pandemic?
A couple of comments. One is that yes, of course, if these increased ventilation rates are achievable, then any airborne contaminant, infectious or otherwise, would be reduced very, very quickly. My concern is that some of these recommended levels are not readily achievable by mechanical ventilation or even in-room filtration. We have essentially 3 modes of disinfecting air. Most buildings that are in healthcare in this country are mechanically ventilated, so the actual number of air changes in a room is essential for comfort and all the other things I mentioned, heat control and CO2 levels, etc. And the other mode that has been widely used during COVID, as you know, is filtration. Now, the filtration can be in the ventilation circuit, and I'll have something to say about that, or it can be filtration within the room, room air cleaner type approach. And the third modality that is evidence-based is germicidal UV, and something that I've been involved with, again, for approximately 40 years, since we installed germicidal UV in a homeless shelter in Boston to control tuberculosis transmission. Again, all are evidence-based. The recommendations here, I would argue, are not necessarily evidence-based. They are more theoretical, as I mentioned for CDC, than they are evidence-based. It's not like somebody had done a controlled study and showed that there was much more transmission with 6 air changes than 12 air changes. One would expect that to be the case, but there are not very many studies at all of interventions to prevent transmission. There are probably more for germicidal UV than other areas. Even for room filtration, very, very few studies of actually preventing transmission. Now, air changes. An air change is when the volume of a room is delivered and removed from that room. Now, the way it works, you have to assume well-mixed conditions, or we tend to. And if under well-mixed conditions, when the volume of a room has entered and left, 63% of the contamination is removed, 37% of the contamination remains, because that air that comes in mixes with the existing air, and what leaves is there's a probabilistic aspect to it of how much of, it's not like a pump being pumped through the room that all of the air is removed. Mixed air is removed, and statistically 67% is reduced. The next air change removes 63% of what's left, and the next air change removes 63% of what's left. So you find that there's a so-called asymptotic curve as you're reducing and reducing. There's a very practical way to think about this, and that is that doubling the ventilation reduces the contamination by approximately half. Doubling the ventilation in a room is a big challenge, going from 6 to 12, and that reduces risk by half, contamination and risk. To get further down, if you double it again, now going from 2 to 4, 6 to 12, 12 to 24, as you see here in the patient room, that is almost impossible under most circumstances, and you're only reduced risk by a half. So in a case of the welfare office that I published, the paper I mentioned from 1991, we had 27 of 67 vulnerable people infected under conditions that were low acceptable ventilation for an office building. We doubled it from 15 CFM per person to 30, we'd go down to 13 infected people from 27. If we doubled it again from 30 to 60 CFM per person, I'm jumping around from air changes to CFM per person, we are down to not 13, but 7. But you don't get down to 0. You keep doubling ventilation to get reduced risk by half. That's the way it works. And if ventilation is not perfectly mixed, it may not be as good as that, or it may be better. But that's, we assume mixed, well mixed. The other point I want to make is that most infectious diseases and airborne infection, and COVID in particular, have been thought to work on a super spreader principle, that a relatively few cases are responsible for a lot of transmission. We've seen this in the published outbreaks from conventions and choirs, et cetera, during COVID. It's not that there's this uniform level of infectiousness that we're trying to deal with, as there is uniform generation of CO2 or heat by people in a room. So in a way, you have to be able to deal with very infectious sources, or you're going to have transmission despite your comfort level ventilation or even enhanced ventilation. So the meaning of that is that I don't think that's been very much taken into consideration and it's difficult to take into consideration in these recommendations. How do you deal with a super spreader? And that was the point of my 1991 paper, The Theoretical Limits of Building Ventilation in Preventing Airborne Infection. And it makes this point. So, 6 air changes. One other point is that if you have poor ventilation, the risk of transmission is extraordinary. And going to good ventilation results in a dramatic reduction in that risk, but not to zero at all. And to get more and more protection, you need more and more and more ventilation. So I think these forthcoming 241 recommendations, if you're talking 24 equivalent air changes, for example, in a patient room, you're going to have very good protection. A waiting room, 40 air changes, if it's a crowded waiting room, would be very good, but also probably unachievable by air movement alone. So what I see these recommendations as is a real call for an alternative method to disinfect air that doesn't involve moving air exclusively, and that leads you to germicidal UV as the only evidence-based technology out there. Now, what about air cleaners in rooms? Oh, two things, one more before we get to that. What about filters in ducts? They've been called for MERV 13 filters. And indeed, for many purposes, a MERV 13 filter is going to be much more effective than standard filters, which are designed to remove dust, essentially, and large particles. So MERV 13 filters will get rid of most viruses, et cetera. However, I would say that you'll be hard-pressed to find a single example in the literature of COVID-19 that suggests that a person in one room without any physical contact infected persons in other rooms through the ventilation system. It happens in TB, it happens in measles. It has not been reported, to my knowledge, for COVID. Whether it's the fragility of the virus, you can find virus RNA in ventilation ducts, but you don't find reports of transmission of infection. There is one report of a toilet vent where people in different floors were infected. That's quite a different matter, much less dilution. And that's the other possibility, is that dilution in ventilation really reduces the viral load to below the threshold that is needed for infection. But at any rate, so I think MERV filters in ventilation systems are a good idea. They could reduce overall flow by increasing resistance and thereby actually reduce protection that ventilation is producing. But for some things, they may be quite useful in buildings. Filtration in rooms, room air cleaners, we've seen a lot of those. We put them in our gym in my building because ceilings were low and we couldn't even think of doing germicidal UV of the type that we're used to using. And so, but they're noisy. They move a limited amount of air, and it's difficult to achieve anything like the air change equivalents that are recommended here with acceptable noise, et cetera. So in our gym, we targeted 6 air changes, and I would not want to have a conversation with someone in the room, because even though they're very high quality air filtration machines, they are noisy and large. I know of a study in England where air cleaners were used in schools, and invariably the teachers turned them off because they couldn't really be heard. So there are limits to what you can do in room with air filtration to achieve anything near these levels, and with mechanical ventilation, it leads you to germicidal UV. I've lost track of our question at this point. I've gone on so much, so stop.
No, you're fine. I think that leads in perfectly to where we want to go with this, which is sort of, we've talked about the basics of what these standards are, where they come from, who's putting them out there. And now it comes to what does it mean for you? And I think you've already touched on this a bit of how then can someone go or an organization go and comply with these standards? What you were recently mentioning around the lack of sort of room to room transmission through a ventilation duct, then really the MERV 13 filter approach probably isn't the best for that. So what are the valid approaches? What we've laid out here, I think, are three that you've touched on, which you're calling sort of the evidence-based approaches. And we can go through some of the pros and cons of them. But this is what a building manager might be thinking about when he or she is thinking, how do I go ahead and comply with this? So there's increased ventilation through your HVAC system already. There's these portable air filters with which Dr. Nardell just touched on. And then there's in-room germicidal UV. And so if you see here, one of the main factors is we're trying to get up, especially in healthcare spaces, to often double-digit EACH values, is how much air are they able to clean? That's really what this becomes about. That's where the measure of EACH or clean air delivery rate or CFM, that's all what it's getting to, is how fast and how much air can you clean. So if we're to look at these, with your typical HVAC systems, they're often running at 70, 80% of capacity. So without upgrading the full system, which might include replacing the blower so you can have a stronger, faster blower, increasing the size of your ventilation ducts, your ability to increase that ventilation is around that 20 to 30%, running it at 100%, which is limited in the total airflow then it can get you. Similarly, with portable air filters, they might be able to add 1 to 3 EACH sort of per device. And so as you're trying to get up, even as Dr. Nardell said, even to just 6, it might be pretty obstructive and noisy. You can't really have conversations, but you can sort of target them to the rooms where you need risk, which is a little bit harder to do on the HVAC side. And then there's in-room germicidal UV, which is obviously the approach R0 has taken with complement to the basic IAQ that is provided by HVAC. So overall, one of the benefits I'd say to GUV, and correct me if I'm wrong, is just the sheer amount or volume of air it can sort of disinfect as once is one of the primary reasons it's able to achieve those high EACH values 10 and beyond. It's really difficult to move so much air through a filter, through the ventilation duct. And what GUV does is it's taking this sort of air in place for the upper room, which is a very common model or approach to in-room germicidal UV, is, you put the device about 8 feet up on the wall, and everything there and above is getting disinfected at once, which is a very large volume of air. And that's how you're able to get such a high sort of clean air delivery rate. But all of these sort of have their different pros and cons. And I would just look at these relative to the numbers that folks will be trying to hit based on the new standard. So I'd say, Dr. Nardell, to you, and you've touched on some of this already, but what are your thoughts on how organizations can meet these new guidelines? And with germicidal UV, is it the sheer magnitude of air it can disinfect at once, or are there other considerations that folks should be taking in, should be considering?
Well, I've done research on germicidal UV, in particular, one study that we did in South Africa, because it was based on tuberculosis and we really couldn't do it here, was an actual TB hospital where all the air from the room was removed and delivered to exposure chambers where living guinea pigs were housed, hundreds of them, and they're extremely susceptible to tuberculosis, more so than humans. And that was used to quantify the amount of TB in the air with the UV on, with the UV off. And what we did was we turned on the UV one day, the air went to one guinea pig colony, the next day to a different guinea pig colony. And at the end of 3 or 4 months of exposure, we had 80% less infection in the rooms on the days when the UV was on compared to the days when the UV was off. So this was a perfectly controlled study, the same patients always on alternative days. And the only difference was whether upper room germicidal UV was on. Now, we also had low velocity ceiling fans operating, which helped to deliver the air from the lower room to the upper room, where it's disinfected and back again as disinfected air to the lower room. UV works optimally with good air mixing. Upper room UV does, and but it also works pretty well with convection currents in a crowded room. We're all essentially, I don't know, 60-watt bulbs the equivalent of 60-watt bulbs generating heat that sends the air around us to the upper room, and then it comes down again very slowly, quietly. So it's not like air cleaners. But this is not just one study. There are countless studies in chambers and other studies done with UV using the guinea pig model that Richard Riley championed back in the early 60s. So Riley I mentioned as my mentor, and he actually was often quoted as saying, ventilate for comfort, but basically irradiate for disinfection. And by irradiating, he meant upper room germicidal UV. And I think it's a good adage. We need ventilation. We need it for comfort. We need it to remove toxic chemicals, etc. But it is ill-suited to achieve the levels of ventilation that are needed for highly infectious patients. So I think that adage is absolutely true. So in that study, what I mentioned, an 80% reduction in transmission of tuberculosis on the days when the UV was on, that was the equivalent of adding 24 air changes, equivalent air changes, to the existing 6 air changes. So these apparently were fairly infectious patients, and we achieved 80% protection with 30 air changes per hour. So the numbers that ASHRAE is proposing are not outrageous. They're just almost impossible to achieve with mechanical ventilation or room air cleaners. But they are achievable with upper room germicidal UV and with the newer whole room far UV, which has the advantage of not really depending on air mixing between the upper and lower room, and allows disinfection between individuals in the room and you can be exposed to far UV. So the other factors, of course, that you'll hear about are safety. Now, you will not see hardly any mention of germicidal UV in the ASHRAE document. You will see it in the CDC document as a supplement to ventilation, which I think is perfectly correct. You need ventilation for comfort. You supplement that for air disinfection with germicidal UV. With ASHRAE, I think the document is extraordinarily biased toward ventilation and filtration, even though it's clear that you can't achieve the levels you need with those two modalities alone, with very little mention of. So, of course, that was the nature of the comments that I and many other people made in response to this draft document. Safety is the other concern. And again, we have 40, 50 years of experience with the safety of germicidal UV. Some are concerned about the generation of ozone by the very low wavelength 222. But even that is taken care of by the necessary ventilation, which you have to have in buildings so it doesn't accumulate as a concern. There is a little ozone produced by 222, very little produced by upper room germicidal UV. Stop there.
Perfect, thanks. We won't belabor this point too much, but we can just briefly talk through, then what are the steps for organizations to get into compliance? And, again, I'll caveat that you can start doing this now, but it would be, you'll finalize those numbers once the final ASHRAE 241P is out. But you could start looking now at basically steps 1 and 2 are determining the gap between your current ventilation and what's going to be required in 241P. Select your approach to fill that gap. And it doesn't have to be one solution. It can be a combination of solutions. Your existing HVAC system, you could choose to use portable air cleaners in some rooms, GUV in other rooms. Implementing that solution in a way that's minimally disruptive to your building's operations. And I think this is an especially sensitive topic in healthcare, where it's pretty tough to have hybrid work, and maybe, offices can use a day where folks are at home to do these sorts of installs. Schools can maybe use the summer. It's difficult for anyone, but especially in healthcare, it's a bit more of a 24/7 operation. So finding a way that minimizes the disturbance to, day-to-day operations is going to be key. And then number 5 would be continuously monitoring and ensuring that these systems are meeting that standard. And this applies to all of your different approaches, whether it's replacing filters in duct or in portable air cleaners, changing the bulbs for UV, and all those sorts of things. A way to make sure that you're continually keeping up and protecting your occupants. Dr. Nadel, any comments here about the other considerations outside of the sheer sort of power or clean air delivery rate?
There's John, there's the energy concern. When you bring in outside air, which is what ASHRAE considers infection-free air, unless it's been filtered to create infection-free air, you are going to have to heat, cool, dehumidify that air. And the energy implications are proportionate to the air changes per hour or the CFM per person. It's a very expensive, and I would say not compatible with current concerns over climate change. So I know the Department of Energy, the U.S. Department of Energy, is very, very interested in replacing ventilation as a infection control modality with germicidal UV because of its dramatically less energy requirements. UV itself is not energy intense compared to the moving air. Room air cleaners are less energy intense than mechanical ventilation with outdoor air. But again, can't achieve 10, 12 or more air changes per hour without unacceptable noise and et cetera. And there are costs with running those machines. Most will increase your air changes per hour by 1 or 2 air changes, depending on the size of the room and the size of the unit, but not very impressive increases in air changes with acceptable noise. But anyway, energy is a big issue that I think we're going to be hearing more and more about as we see the dramatic effects of climate change on our lives.
Absolutely. Thank you for bringing that up. And I'll mention that, in the studies that, we had a third party conduct a study to model out what the difference is between achieving these higher levels of equivalent ventilation with HVAC-based ventilation or a upper room GUV system. And the results are pretty astounding. They found a 95% reduction in the energy and greenhouse gas emissions required to achieve those levels of equivalent ventilation by using ultraviolet light. So thank you for bringing that up. I think it's a really good point. It looks like we have about 15 minutes till the hour. So let's jump into the Q&A and start fielding some questions that folks might have now that we've covered the basics.
Yeah, thank you so much, John. And thank you, Dr. Nardell. What a great presentation. And I think we're seeing record-setting engagement from our audience. We have a lot of audience questions that have come through. So I think we can go ahead and get started on the Q&A session. And to any audience members who haven't yet asked a question, if you'd like to, you can do so by typing it into the Q&A chat box on your webinar console. Okay, and we will get through as many as we can. But all right, so our first question that we have is, will there be different ACH for operating rooms?
So I will say these are so far what's in the draft 241P standard is what we put on those slides. Perhaps in the final version, they'll go even more specific, have even more specific spaces within the healthcare environment. I was a little surprised to see that there weren't those specifics, and it could be because they're moving rather fast. You may or may not be aware, in the ASHRAE 170 standard, there are separate ACH requirements for operating rooms. What the 241P draft says is basically pick the space type that is closest to what we have here, whether that be an exam room, patient room, or waiting room. So that's what we've seen today. They may expand on that in the future.
Got it. Super helpful, John. Thank you. Okay, next question. Can an older system really go from 12 air exchanges to 40?
The answer is, in my opinion, not an engineer, very, very, very unlikely. As mentioned by John, most systems are working more than certainly 50% of the capacity, and probably closer to 75% or so of their capacity. So there isn't a lot of wiggle room in terms of how much more air you can get out of an existing system. Again, putting in a filter, if it doesn't reduce your airflow by resistance, certainly produces the equivalent of 100% of that being outside air. So if you had 6 air changes coming out of a system, and assuming that didn't change by putting in MERV filters, you suddenly go from 1 or 2 outside air changes, depending on whether it's variable or fixed outside air fraction, to 6. And that's a big increase. But it isn't 12, and it isn't 40, and it won't be. So, I think there are limits to what mechanical ventilation in existing buildings can do. And in new buildings, wow, I mean, there are very few buildings in existence that have that kind of ventilation. I think the industry would have to build systems that are designed differently than current ventilation systems are designed to achieve those numbers.
Very helpful. Thanks, Dr. Nardell. Next question is, are the proposed regulations proposed as retroactive?
Oh, I don't think so. I mean, well, retroactive in the sense that if you have existing buildings, those, I think those are still the recommendations. I'm not clear, John, I don't know if you are, on new construction versus renovation. Yeah, these are the recommendations, but you may have a comment on that. CDC is, I think, probably applies to both.
Yeah, this comes up all the time, so I've had to look it up a number of times just to make sure, because it comes as a surprise. At least what's in the draft standard, what they've stated as the scope is both new and existing buildings and any additions to existing buildings. What the enforcement looks like, we certainly don't know, but what the scope has said is that, yes, it would include existing buildings. So it's, at this point, it's not like you're grandfathered in if you are already existing.
Got it. Thank you both. So this next question comes with a little bit of context at the top. Researchers published a very interesting investigation of impact of natural ventilation on transmission of TB in healthcare facilities in Peru. They used CO2 tracer to estimate ACH. Any comments on the use of CO2 as surrogate for assessing indoor air quality and mitigating the risk of transmitting airborne diseases?
I'm very familiar with Rod Escom's study in Peru. First of all, let me tell you, there are a few breezier places than Lima, Peru. So opening the windows there certainly can achieve 60 air changes per hour, and the climate is very mild. So it's many places in the world depend on natural ventilation. CO2 is a acceptable and useful way to get a handle on. I'm looking at a CO2 meter and I have it in my condominium here that I just leave running all the time, and you have a sense of what happens when people come in, etc. It's useful. It's imprecise, depends on outside levels of CO2, but good meters, I'll get the one I have here. This is not an advertisement, but this little meter is showing, for example, 770 parts per million of CO2. As I'm sitting here, it tells me the humidity and the temperature as well. And outside is roughly 500. So this is the result of relatively little ventilation. This is not a mechanically ventilated room, and the presence of one person in this vicinity. So yeah, useful way, and it has been done extensively during the pandemic. Actually, mine just jumped up to 1,264, so I think it has to do with my talking a lot.
Dr. Nardell, would that work across methodologies or only for sort of ventilation and filtration? Would it work for in-room GUV as well to tell you?
No. Of course, CO2 is removed by outdoor air. If even recirculated air, right? CO2, if you have recirculated air, air cleaners in the room, or even recirculated air through the ventilation system, you're going to be building up CO2. Now, CO2 itself isn't harmful within a very high range. CO2 on a submarine can reach 10,000 parts per million, and people are able to function. It happens gradually. But normally we like to keep it less than 1,000. And so right now in my condominium, we're above the level that most people would like to see. Of course, I'm probably talking at it, and it's absorbing the CO2 that's near me from my exhale breath. But it certainly won't tell you anything about about UV effectiveness. It's only for how much air is. It gives you a ratio essentially between occupancy and ventilation.
Yeah. Okay. Perfect. Yeah, and if you use something like UV, you'll need to use an alternative method for verifying your EACH. What we often do is through sort of computer simulation modeling, as well as there are some other methods being developed by third parties and other companies and organizations for verifying the EACH from UV. We can jump to the next question.
Great. Thank you both. All right, next question. In our higher ACH patient rooms in a pediatric facility, parents complain about the AHU blowing too much air on them while they sleep, especially in positive pressure rooms. Is there a remedy for this?
I think it's more of an engineering question. I mean, I think a lot has to do with the design of the registers that deliver the air. They can be changed so they're not blowing on people in their beds, but I think that's probably not on topic right now.
Yeah, I would say, without trying to talk our own book too much, that is one of what we would see as a potential upside of using something like UV. Rather than having to move so much air, you're able to get the same or better disinfection without having to move air that could cause occupant discomfort. But there are probably also engineering controls that could make it a little bit more comfortable without having to switch to UV, but it is difficult.
Got it. Thank you. And we have another question kind of more specific to the type of facility. So have you thought about how to address spaces where the occupancy varies significantly over 24 hours? For example, waiting rooms in the emergency department, et cetera.
Well, that's why I don't really favor the per person prescription that the new 241 uses, because of the fact that occupancy varies so much. If you deal with room air changes per hour, you do have to worry about not overcrowding the room, but you're not as likely to, design for a room that is less crowded than. At any rate, so I don't think you can vary the ventilation. Well, actually, that's not true. There are ventilation systems that run on CO2, actually, that are variable delivery systems. At Harvard School of Public Health, they have some rooms. Because they're lightly occupied, the ventilation turns down because the CO2 levels are low, and as the CO2 levels rise, the ventilation rises to meet that demand. We don't see this in the 241 as a recommendation, but I think it is a rational one to deal with the issue you raise. With germicidal UV, it really wouldn't matter how many people are in the room, so it's a different approach.
Great, thank you. Okay, so kind of in the same vein, does the standard address other areas of healthcare, such as airborne isolation rooms and procedural areas like the ORs and cath labs?
I think this one's been addressed. I give my same answer to before about the ORs. It is addressed in ASHRAE 170. Those specific room types have not been included in 241P. Perhaps they will be either with the final or a revision later on. For now, the guidance is to use the room type that's closest to the ones they have provided.
ORs are already extremely well ventilated, and if you've been in OR either as a worker or as a patient, you realize that they tend to be noisy from the ventilation system, and also you feel the air and sometimes overly cold, but at any rate, they are already well ventilated.
Thank you so much. Okay, I know we have only about 4 minutes left, so we'll probably be able to squeeze in another question or two. Thanks again, everybody, for all the cues you've submitted so far. So this one is, what would the recommendation be for hospitals to consider regular ductwork cleanings?
I'll just comment here. My understanding from my engineering colleagues is that generally speaking, ductwork cleaning has nothing to do with airborne infection control. I mean, I think it may not even be necessary for other purposes, but it's nothing to do with airborne infection control. We don't worry about, pathogens accumulating in the ventilation system. If they're on surfaces, they're out of for airborne infections, they're out of the picture. They're going to die there, and they're not going to get re-aerosolized. So I wouldn't worry about that. There was a question I just want to throw in quickly that someone mentioned, their understanding was that UV worked on surfaces. In fact, UV does work on surfaces, but it works much, much, much better in air. The problem with UV is it doesn't penetrate surface dust and things like that so well. So it's not really, it can be used for surfaces, but in very high intense reasons for example, hospital room cleaning between patients for a variety of reasons, but it is much more effective in air than on surfaces.
Yeah, so for example, R0 will use it on surfaces, as Dr. Nardell mentions, in between patient room turnovers, and they'll do it in an unoccupied space, and then you can use that higher intensity UV light.
Someone asked about bipolar ions, and it is a technology that there was enthusiasm for mostly by the companies in the beginning of the pandemic, but really there has been no real good evidence of efficacy in any way comparable to what we're talking about here.
Got it. Thank you both so much. And I think we have time for this one final question. It's kind of a good segue. We were just talking about UV. How harmful is UV with long-term exposure with patients and healthcare staff?
Very good question. I'm glad you got that in. So germicidal UV has been used again for almost 100 years, and the threshold limit values are very well established. Now, germicidal UV is UVC, and its main asset is it doesn't penetrate very well. So it doesn't penetrate the outer dead layer of the skin particularly well. So we have very good exposure limits. The 8-hour exposure limit for upper room mercury generated UV is 6 millijoules. You could get 240 millijoules of penetrating UVA and B, the kind that causes cataracts and skin cancer, outside on a sunny day in 4 hours. So we're talking about minuscule exposure. Long term, again, the thresholds deal with exposure time. So you're allowed to have within any 8-hour period, the 6 millijoules, and then the next day you can have 6 millijoules or more, and we say well below that. So it is really a very safe technology in my view.
Yeah, and I just want to add, thank you. We will try and get all of these questions answered. We'll be continuing to post things on our blog or newsletter where we really appreciate all these questions. I'm sorry we couldn't get to all of them. We're going to record them. If you want to ask another one, you can scan this QR code, add it to a question bank, and we'll continue to be answering them over the next weeks and months likely. We know this is a big change for a lot of organizations, and we want to be there to try and help out and answer the best we can. And also, thank you so much to Dr. Nardell, whose papers and research and articles have really helped me ramp up on this for ever since I've been in the space.
Yeah, thank you, John and Dr. Nardell. This is a fantastic presentation, and I think if all the questions are any indication, lots of interest on this topic. So thank you again, John, for letting folks know where other resources live. And we'd also like to thank R0 for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you so much again, everybody, for joining us. We hope you have a great afternoon.
Thank you.